I know y'all missed that, don't you? The Committee on Insurance and Financial Services shall come to order. Mr. Clerk, will you please call the roll to establish a quorum?
Representatives Carter,
Present.
McFall,
Here.
Coleman,
Here.
Stone,
Here.
Breen, Rogers,
Here.
Scott,
Present.
Young,
Here.
Fitzgerald,
Here.
Grant,
Here.
Harris,
Here.
Markkinen,
Here.
Bizat, Aragona, Bruck,
Present.
Nyer,
Here.
Smith.
Present.
Madam Chair, you have a quorum.
Thank you. Now we need a motion to adopt the minutes of June 22nd, 2023. Representative Scott moves to adopt the minutes as printed. Hearing no objections, the minutes are adopted. First on our agenda is a referral of House Bill 4131 to the Committee on Health Policy. Representative Rogers moved to refer Bill 4131 to the Committee on Health Policy. Mr. Clerk, would you please call the roll?
Representatives Carter,
Yes.
McFall,
Yes.
Coleman,
Yes.
Stone,
Yes.
Breen, Rogers,
Yes.
Scott,
Yes.
Young,
Yes.
Fitzgerald,
Yes.
Grant,
Yes.
Harris,
Yes.
Markkinen,
Yes.
Bizat,
Yes.
Aragona, Bruck,
Yes.
Nyer,
Yes.
Smith.
Yes.
Madam Chair, you have 15 yeas, 0 nays, 0 pass.
Thank you. House Bill 4131 is referred to the Committee on Health Policy. Next on our agenda is a testimony only of Senate Bills 356, 357, and 358, introduced by Senators Hertel, Kavanaugh, and Kleinfeld, respectively. Here to testify on all three bills is Senator Hertel, and here to provide additional testimony on Senate Bills 356 and 357 is Dr. Jennifer Morse, a board-certified family physician and member of the Michigan State Medical Society Board of Directors. Thank you both for coming forth. The floor is now yours.
Good morning, Madam Chair, and thank you for hearing these very important bills today, and good morning to the committee as well. It's always nice to be back over in the House. I know you guys took up House bills that we also worked on in the Senate as part of this package, so you're very aware of the issue that is before us. So I'll keep my remarks somewhat brief, as I know you know the importance of this issue. And really, the Affordable Care Act is probably one of the most consequential pieces of legislation that has been enacted in my lifetime. It provided affordable access to health care for people all across this country. And we want to make sure that if anything were to happen to that federal law, that here in the state of Michigan, those protections still exist. So my bill, Senate Bill 356, would ensure people are fully informed of what their insurance policy covers by requiring insurers to provide the terms and conditions of a policy at the time of application, issuance, upon policy renewal, or at the request of the insured. And as we continue to work through the unwinding of Medicaid following the COVID-19 emergency, it is more critical than ever that those utilizing the healthcare marketplace have access to the information they need to make sound choices. This legislation will ensure that residents are able to make the most cost-effective healthcare decisions for themselves and their families by plainly stating what their policies cover. Senator Kavanaugh's bill, Senate Bill 357, would prohibit insurers from rescinding coverage with exceptions for bad faith actors. Finally, Senator Kleinfeld's bill, Senate Bill 358, prescribes levels of coverage at the state level to match the federal tiers, known as the bronze through platinum options. Together, these bills, in combination with the House bills that you previously acted on in the spring, will ensure that all Michiganders continue to have access to care coverage regardless of what happens on the national stage. I want to thank you for your time on this, and I want to thank the many folks, including Representative Rogers on this committee, that has put a lot of work into these bills, and yourself, Madam Chair. It has been very complicated to take what is federal law and make it work here in our state statute. And so a lot of people put in a lot of hours with the department and others to make sure we got this right with all kinds of stakeholders, including insurance companies here in the state. And so while it's been a big undertaking, I think it'll be well worth it to make sure that Michiganders have protections under the law here in Michigan to be able to keep their health insurance that they have today. Thank you.
Good morning, Chair Carter and esteemed members of the House Committee on Insurance and Financial Services. Thank you for the opportunity to share the perspective of Michigan State Medical Society, also known as MSMS, and its members on the important bills. I'm Dr. Jennifer Morse. I'm a board-certified family physician, and I'm the medical director of 3 public health departments: Central Michigan District Health Department, Mid-Michigan District Health Department, and District Health Department number 10, which covers 19 counties in our Lower Peninsula. I'm also a member of Michigan State Medical Society Board of Directors. On behalf of MSMS, Public Health, and myself, I'm here to express support for this package of bills codifying the Affordable Care Act provisions, particularly Senate Bills 356 and 357. All of these bills are vitally important to the health and well-being of all Michiganders. As a physician, we all have witnessed firsthand the immense challenges patients face when insurance coverage falls short or when it's just not available. As you may know, on March 30th of this year, a judge in the U.S. District Court struck down a critical provision in the Affordable Care Act that requires most private and health care plans to cover a range of preventative services without any cost sharing for their enrollees. Should this ruling hold, millions of individuals can find themselves burdened with the exorbitant costs of preventative health care. And even worse, some may lose access to essential services altogether, which in the long run is going to cost us much more. Our unwavering commitment to deliver the right care at the right time to the right patient and thereby fostering the best patient outcomes compels us to recognize the dire consequences of uncertain or lost health coverage. When the process of securing insurance becomes convoluted, burdensome, or financially disastrous, too many individuals are left without the coverage they urgently need. This is precisely why MSMS stands firmly behind these bills. They present a pivotal opportunity to ensure patients receive the transparency they deserve. Insurance would be mandated to furnish written forms detailing the terms and conditions of their policies at the time of application, issuance, and renewal. By empowering patients with comprehensive knowledge of the benefits covered under their plans, we can dismantle barriers to accessing quality care. Moreover, these bills unequivocally prohibit insurers from rescinding coverage unless an enrollee has committed fraud or intentionally misrepresented material facts. Notably, insurers would have to require written notice to the enrollee at least 30 days before issuing any rescission. By providing these vital provisions in law, you can help safeguard the health care coverage of countless individuals, freeing them from the constant fear of losing their health care coverage. Additionally, by codifying the protection, my colleagues and I will be equipped to wholeheartedly advocate for regular checkups, screenings, and other preventative care measures. It is a well-established fact that these preventative interventions significantly improve overall healthcare outcomes, make healthcare cheaper in the long run. And as a family physician who now works in public health, I know these interventions save lives. By ensuring that patients can access these essential services without fear of financial ruin, you can help pave the way for a healthier and more resilient Michigan. So on behalf of Michigan State Medical Society, I respectfully request your favorable consideration of these bills. So thank you again, Chair Carter and members of the committee.
Thank you, Senator Hertel. Dr. Morse, for your testimonies. Thank you. Members, are there any questions? Representative Brooks.
Thank you, Madam. Thank you, Madam Chair. Thank you, Senator and Doctor, for being here today. I have two questions. One deals, you mentioned litigation that currently that went against one of the provisions of the ACA. My question is, if we codify something in the state law that is controversial or up to litigation, does that put our state in jeopardy for further litigation? And then my second question is if the ACA changes nationally at a national level, does this automatically be reflected on the state adoption of those laws? Thank you very much.
Thank you for the question, Representative. I would say that any court ruling that impacts the ability to implement any portion of the ACA, obviously we would have to address here within state law. But these are merely a protection point to say that if this were to go at the federal level, and it could be through a court ruling, would have to address that here within the state. It could be through a repeal in Congress. We continue to see attacks on the Affordable Care Act from many different levels. And so the goal here is to make sure that this is enshrined in state law. The protections will exist with whatever could occur at the federal level. Because those protections are being utilized today by people across all of our communities and would upend lives if they were to be taken away. And so this is really a proactive approach to say, if something were to happen, we want to make sure these protections stay in place. Any court ruling would have an impact on any law that we have here in the state, and we'd have to address that. As it occurred, I would not want to assume how that, what could be ruled and what would happen.
Representative Harris.
Thank you, Madam Chair. And Senator, Doctor, thank you guys for being here this morning. I appreciate it. I have two questions with the Chair's permission. One is just a follow-up on Representative Bruck. So, Senator, I just want to make sure that I clarify this with you. So are we saying that this will be in place if something in federal law goes awry, so it won't take effect unless federal law fails in one of these areas, or is this something that will currently be in place with federal law?
It will be within our state statute, but the federal law is what takes precedent, right? So the federal law is what will essentially be working today until that is removed. This will make sure that these protections stay in place within our state.
Okay. And anything in these bills, does it expand any of the aspects of the ACA, or is this purely a codification?
No, and that's why I say this took a lot of work between stakeholders and everybody else. I mean, you'll notice the bills that you passed previously out of this committee from the House side, the bills that we took up, there were concerns from some that it might have went a little further or would have required insurers in the state to do more than they do under the ACA. We worked very closely with all of those stakeholders to make sure that this does not go beyond what the ACA requires, simply that if the ACA were to go away at the federal level, those same protections will exist here in the state. It will require insurers to do nothing more than what they currently do today.
Okay. Thank you.
Thank you. Seeing no further questions, I'm going to read in the cards. Not wishing to speak but support the bill, Frank Waters, Michigan Primary Care Association, MPCA. Not wishing to speak but supports the bill, Adam Kasker, Michigan Hospital Association. Is that right? Not wishing to speak supports the bill, Kate Dorsey, Michigan State Medical Society. Not wishing to speak and support the bill, Joseph Sullivan, DIFS. Wishing to speak. If there's time.
Otherwise, written comments provided. So
Okay.
if she's got time, we can bring her up.
Yes. Rachel Richards, would you like to come up? A few minutes. Thank you very much for your testimony.
Thank you, Madam Chair.
Thank you, Madam Chair and members of the House Committee on Insurance and Financial Services. I'm Rachel Richards. I'm the Fiscal Policy and Government Relations Director for the Michigan League for Public Policy. For those of you who aren't aware of the Michigan League for Public Policy, we are a nonpartisan research and advocacy organization that works towards bettering health, educational, and economic well-being outcomes for Michigan residents who have been historically and systemically left out of prosperity. We are pleased to support the bills in front of you today, Senate Bills 356 and 357 and 358. As you all have my written comments, I just wanted to highlight a couple of things. One, we know the significant beneficial impact that the Affordable Care Act has had on healthcare access in the state and nationally. We know that our rate for those that lack insurance has drastically declined since the enactment of the Affordable Care Act and has even outpaced the national declines in the uninsured rates. More kids have coverage and more kids live in families whose parents have coverage. And I want to kind of highlight the reason why that this is important and the reason why healthcare is important is because it improves both health outcomes and non-health outcomes for Michigan residents. Children in insured households are more likely to be seen for well child checkups and acute care. They miss fewer days of school due to illness and injury, do better and stay longer in school, grow up to be healthier adults, and earn more as adults. We also want to ensure coverage because it also helps improve the financial stability of Michigan residents by protecting them from medical debt and making sure that they can afford medical care and other basic needs such as housing, childcare, and food. With all of the great gains that we've made through the Affordable Care Act, we think it's really important that we codify these provisions in law currently to make sure that because we don't want to take steps backwards should the Affordable Care Act at the national level be repealed for some reason. So as previous speakers have said, with all of kind of those previous and ongoing attacks, we think now is a great time for us to be putting these provisions into state law to really protect the health, educational, and economic security of Michigan residents. So thank you for your time, and I'm available for any questions.
Thank you very much for your testimony. Are there any questions? Hearing none, thank you. And I do want to make a correction. Adam Carlson of the Michigan Hospital Association, not wishing to speak and supports the bill. Thank you. Next, Representative Rogers has an amendment identified as something we didn't put in there. Yeah. As we only are hearing testimony this week, we will take up the amendment when we hear this bill again next week. Okay? Now, colleagues and visitors, as you all know, in 2019, there were changes made at the state level to auto insurance. The system of Michigan's auto no-fault was modified. The intent of these changes were to lower our auto insurance rates, which were some of the highest in the nation at the time. We wanted to bring costs down while continuing to protect Michigan drivers. What I hope to communicate clearly is that I want every member of this committee and every Michigander to know that that is our goal. We owe it to the people of Michigan to fix the problems with auto no-fault. Starting September 28th, we will dedicate time during our committee meetings to address how to best move forward regarding the auto no-fault law. We will continue educating ourselves with more deeply on the nuance of this complex system. We will hear from various stakeholders. And of course, we will hear stories from Michigan drivers who were most affected by the 2019 change that went into effect. Today, we will begin with a warm-up, an introduction into diving deeper and tackling the problems within our auto no-fault system. I asked Fair Health to present as a great next step in reviewing our fee schedule. With that, here today from Fair Health are Donna Smith, Chief Client Officer Christine O'Donnell, Executive Director of Government Engagements Allison Snyders, Deputy General Counsel. Thank you all for coming. Please come forward. The floor is yours. And we are deeply appreciative of what you're going to share with us about fee schedules.
Thank you, Madam Chair. First of all, I'm sorry, Chris O'Donnell had to take an exception, so she may not be joining us during this time, but thank you so much for allowing Fair Health. Allison and myself will walk through a couple of slides very quickly, if we may, and share with everyone on the committee and in the meeting today about Fair Health. One of the things that I think is important for us to start out is just who we are. I think it's important because of our role in this ecosystem that's not specifically just to auto liability, but to really all of the ecosystem. Many of those that are here today may already know about Fair Health, but if it's okay, we'll walk through some of these slides. Okay. Let's see if I can do this without it. So again, the first thing that's important is walking through our mission. Our mission at Fair Health is to support all stakeholders in this ecosystem, which really is about health insurance in general, transparency, bringing information, whether it's benchmark data, which are from our commercial data, or from other important data sets from other sources like Medicare data, or even information from other fee schedule and experience and consultative analysis and things that we've actually worked in other state and federal agencies. But again, we are neutral, independent, not-for-profit, which is really important because of our neutrality. We work with all of the stakeholders to help inform the commission and the committees on how best to go forward, and that's our role that we would play in this role. And again, this is just a depiction of who we are. We sit right in the middle of the ecosystem, working with all of these different institutions. And it's important, again, for our neutrality. So there are times when we're actually in the middle of disputes where both sides might be using our data or our information and our educational sources to help inform and educate on the really difficult nuances of billing and payment trends, whether it's in the auto liability space or whether it's under a statute or whether it's in just general operational flow for commercial operational, including ACA and some of the other NSA. I can go through the whole litany of all of the different acronyms that we're really placed in, and we're fortunate to be able to help communicate. I'm going to start with just a few things that's important because most of those that might know us for our benchmark data. Our benchmark data is a commercial data set that we collect over 70 plus contributors' data, which are commercial payers in the United States. All of those would be commercial, not Medicaid and not Medicare. We also have Medicare data because we are actually a QE qualified entity where we're entrusted by CMS to have all of the Part A, B, and D data. But what's important about this commercial data is that it is in the world of, as being discussed earlier, the ACA. It can be the exchange market. It can be so many different pieces. But that data that we collect is huge. It's the largest in the nation. We have 70, like I said, 70 plus contributors contributing, and we're gaining more and more of those commercial entities that are adding to this conversation. We take in 2+ billion claim records a day. I'm not a day, I'm sorry, in a year. That's a lot. But the key to this is that we are so granular because of the depth of the data. So we have 493 GeoZips, which generally goes to about the first 3 digits of the zip code. What's important about that is it helps inform some of the really what's specific to the areas in Michigan. It gets to your local areas, and that helps inform some of the decisions. And again, we are a QE qualified entity, which we do collect the Medicare data as well. We do use that to help inform decision making. And again, this is based on consultative, educational, informed decision. So that data is used in multiple areas. The other thing that's important is the way we take all of the data that we are entrusted with, and we categorize them based on groups of medical, dental, anesthesia, HCPCS, inpatient, outpatient, ASCs, and for those of you that aren't familiar with all the breakdowns, those are based on different coding structures. When the providers are submitting their bill that goes into payment, it's based on certain types of codes and diagnosis codes. And all of that is where we also help educate and inform so the committee and all of those in the stakeholder community can really dig in and really know what's important to your state and what's important to your stakeholders and your specialties, and making sure we're taking the voices and help develop some type of informed decision making. This is just a glimpse of all of the different ways our data and our services and support can be helped in assisting many of the different entities. It could be plan design in the carrier space, or it could be in the third-party administration for self-insurance. It could be in policy making. It could be based on the patient, which is really ultimately a part of our mission as well. We have a mission of producing data to help inform the economy, the economic scenarios based on what we're seeing and insights in our different white papers. So you'll see here some of the examples based on even our COVID and looking at the trends and looking at all the different things that have happened over the many years. And as we go through this, we've also provided not only just data benchmarks, but helped inform some decision making based on some of these federal agencies. We've been entrusted with so many different calls, and today, as an example, an invitation to speak and to share what we can help and support. There's not a perfect match for any particular institution or policy or even a fee schedule. It's more about how we provide data and help inform what's best for you and your stakeholders. And I'm going to end this section just by reminding we have a consumer website, which I recommend to you. Please go look at it, but please do not use it unless it's for your own personal use. This is a consumer website that is part of our mission, which is to help inform what the cost might be based on certain services. And this is, again, for our support in helping the patients and the care in this ecosystem. As we move over, we're going to have Allison walk through some of the state legislation and support and how we specifically support those areas, including Michigan.
Good morning, everyone. Good morning, and thank you, Madam Carter, for having us and members of the committee. Appreciate the opportunity to provide this educational background on Fair Health as a neutral entity. So I wanted to talk, I guess, really take an overview of the kind of work that Fair Health is doing really around the country in so many different states and so many different capacities with respect to fee schedule development. This is a sort of I'd say a high-level snapshot. You can see the sort of darker blue circles indicate states in which we're supporting some sort of workers' compensation fee schedule, either providing research, analysis, data. And again, that's not necessarily Fair Health commercial benchmarks. It could be a different, we pull on different data sources and work with stakeholders to develop a fee schedule that makes sense. I'll get to this in a moment, but we're also doing work with many states in the capacity of surprise billing. A lot of that predated the passage of the federal No Surprises Act. We're really fortunate to have this really robust and commercial data set and Medicare data set, and we're also being used in very unusual ways. For example, in crime victims compensation programs, you can see in a couple of states. Obviously, auto liability. We work with New Jersey currently on auto liability, and we'll also get to this in a moment, but supporting Michigan diffs in the current law. We've done work with many states in providing data for ground and air ambulance studies. Also used in California to develop fee payment for emergency care for low-income patients, and then really just a bunch of different other interesting uses of the data for vocational rehab. In Washington State, we're working on public health programs, and in New York, we support a medical indemnity fund for birth-related neurological injuries. So really a lot of very interesting work. The other thing I'll mention is that we're also very fortunate to be working with the Department of Veterans Affairs and Veterans Administration in a dental fee schedule. So again, working with so many different stakeholders in different capacities to provide the right data set and the right sort of expertise that will help you. As I mentioned a moment ago, we do support surprise billing legislation. Fair Health is specifically called out in a number of different states. Texas uses both Fair Health's allowed and charge benchmarks, which really reflect both the provider's billed charge as well as the payer's negotiated rates as sort of guardrails for surprise billing, and similar sort of formulations in different states in Connecticut, Mexico, Georgia, New York. So I think I'm preaching to the choir here a little bit, but obviously, as you all know, Fair Health has been identified in the Michigan Administrative Code as the data source to be used for payment determination appeals under the current no-fault law. And obviously, as you know, it currently provides for payment based on Medicare, but when no Medicare value is available, then you look to the charge description master of that January 1, 2019 data. So where obviously that doesn't exist, then the Department of Insurance and Financial Services is allowed to look to the Fair Health database. And so we have been, over the last couple of years, been working closely with DIFs in providing them, again, that mean charge data from our benchmark products that include dates of service on January 1, 2019. So we are, again, we've been closely collaborating with them on making sure that they have the data they need. We've been providing that data annually, and then Department of Insurance and Financial Services will apply those required consumer price index adjustments. I'll turn it back to Donna.
So one of the things that's, I want to round out that part of it, not only just educating and helping with some of the additional codes, it's also hearing from the comments and some of the stakeholders that have contacted us, because they also license our data, our benchmark data. So we've been able to educate and bring forth to DIFs some of the information and information about the codes and billing codes and why. And of course, under consideration, there have been codes added over the last year. So we've been supporting that conversation. I think what's important here is that data can be used in many different ways, but when you have a fee schedule can actually help inform the maximum allowable amounts. And that's where we've had a lot of experience over the years working with multiple states, helping them inform which are the codes and how they're going to put maximum dollar amounts and the rules that go around that. Workers' compensation is very similar to auto liability. We were actually asked to do this about 12 years ago by a couple of states, and it's grown tremendously. We're not a lobbying group, so we do not go in and really facilitate and start marketing. What we try to do is help inform and be invited as we've been today. These fee schedules have continued to grow because there have been times when they've asked us to start with a certain medical fee schedule, but then they may want to add dental, or they may want to add ASCs, or they may want to do some other fee schedules and carve them out. Again, it's all the same process for us because we go through an educational process. We learn more about what your stakeholders are saying, what are the push and pull, what's some of the information that's actually causing angst, and we bring that forth and share what the different rates and things would be based on Michigan and based on your rural or urban or what have you. The services, again, I mentioned are CPT codes, HCPCS codes, and the CDT codes, which are very common. These fee schedules also, if it's going to be based on it could be based on multiple things. It could be based on commercial data. It could be based on Medicare reimbursement rates. It could be a hybrid or a mixture. It could be some other type of methodology. It doesn't have to be set in stone for each. You could have a lot of different, what we call market baskets, which are different from the Medicare market baskets. There's a lot of different ways that you can categorize these. So developing a fee schedule is really important to have a lot of information and education based on a neutral entity, which would be Fair Health. We would bring forth a lot of information and share with the transparency from the comments from your stakeholders so that you can make some informed decisions. It needs to have the benefits in reflecting the different jurisdictions within your state. It has to have some input from the stakeholders, which in most states, we've never had a problem with that. We've had a lot of stakeholders that have provided many of their comments, and we've been able to bring it together and articulate and educate. The benefits of a fee schedule does help reduce the static. It reduces the interpretations. It helps you define it very clearly to where everyone now knows what that maximum allowable amount would be for that particular code. It can result in participation by the providers to step in because now they know what it is. It's not going to be nebulous. And also you want to make sure you're keeping an adequacy to serving your patients. And that's where we have the benefits and support. Again, I mentioned this earlier about you can use multiple data sources. Fair Health helps with our benchmarks to supply benchmarks and information in the discussion before you adopt a fee schedule. It helps you inform what the carriers and the payments are being on the contract side for the commercial world, It also looks at Medicare. You can also look at different states to see what they're doing, compare some of the rules and see how they've adopted the maximum allowable. Analytic support will go in and do some analysis based on different percentiles, which are, statistical models where you can see where that high and low might be. And again, this is going to be based on what is important to you and your stakeholders. The fee schedule gap fill is also where we are today with DIFs. We're doing a lot of the benchmarks based on our gap fill products, based on our benchmarks. And we can also develop the rates. So we can not only inform the decision making, but we can actually create a rate table. In some of the states, we actually distribute the fee schedule. So it would be on our order page where a stakeholder provider group or any carrier could download those files. And it's easy for them to, of course, load into their systems. And then we also, again, participate in stakeholder meetings, support in the educational process, and take the comment periods and help digest it and inform the committee and the commission on how they might want to go forward based on that information. I know this is a lot of information, so hopefully we'll get through this. But again, our experience has been just really educating and updating these fee schedules, creating fee schedules, developing it to the point where it's not static. You want to have some clear, concise measures in how those reimbursements are going to be. You want to update them every year, annually. Some of the fee schedules we've seen in the past weren't updated in 12 years, and you miss a lot of new codes. A lot of new procedures have been done. And that's where you get caught in being left behind if you don't have a fee schedule that's updated annually. The ground rules and the rules, they also need to be reevaluated based on your stakeholders. What's happening in your community? What's happening in the injured auto liability space? You have to have some of that feedback. And again, we're here to help and support, and I'm just going to round it out by saying, I know we're up for time, so I just want to make sure we're rounded out. We can really dive down into the details, and we can really inform the commission based on all the educational pieces of it and components to help inform a fee schedule. That's our experience. It's not just benchmarks, but it's here to help support any of those conversations. And I'm going to just stop for just to see if there's any questions, 'cause there's a lot here.
Okay, yes, we see Representative Breen has her hand up. Oh, no.
Sorry, I don't have my own microphone. Sorry, Lori.
No worries.
This is a very great and helpful presentation. And so I'm wondering, though, do you have any contracts or business relationships with auto insurers or any home health care providers here in Michigan right now?
Well, I'm going to say, making a general statement, probably yes, I'm sure.
Okay.
We have, yes.
Okay. Can you tell us, maybe some of the clients that you've engaged with? So.
Well, we can't really disclose our clients,
Okay.
but we can say that we have licensees of all the stakeholders that you saw, specialty groups, carriers of any type, auto liability, workers' comp, the whole spectrum. We have licensees across the board.
Okay. Without maybe naming any names, can you tell me whether or not you're working with any of the home health care providers or any of the post-acute care providers here in Michigan?
I will say that I know that we license the data to all stakeholders. I can almost positively guarantee that I know there's some of those kind of providers who are in our licensee pool, because again, with respect to the data that we're currently providing to Michigan DIFs, we also make that data available to the marketplace, the same data set. So, and I know many of those kinds of providers have also sought that data set from Fair Health. So yes.
Okay.
And let me just say, it's not a mandate. So, your stakeholders were not mandated to license our benchmarks, but most of them did contact us and did. So let me also just add, we had comments from some of the licensees that you've mentioned, and we've provided it back to DIFs during the duration of the last year.
No, I appreciate that because,
Yeah.
like I said, this is a very great and helpful presentation, but I'm assuming it doesn't come for free. So
Oh.
I just wanted to know
That's
what
true.
relationships you have, because we're a pretty unique state, especially with workers' compensation, which is my world, if you will. So thank you for this. I appreciate
Good.
it.
So this slide, actually, where I landed, we do work in multiple licensing models, especially for state agencies. The state agency themselves, we have different models where it can be actually funded by the state, or it could be a hybrid where it's partially funded by the state funds and then partially by the licensees that license the fee schedule, or even for the benchmarks. I mean, there's a hybrid, and we've done this in multiple models. So we're very flexible. Again, being a part of our mission, we want to support the state's initiative, which is bringing forth clarity, fair, transparency fee schedule.
Okay.
So,
Thank you so
yeah,
much. Appreciate it.
Thank you. Representative McFall.
Thank you, Madam Chair. I just have two quick questions. One, you say that you're a neutral nonprofit organization. Where do you get your funding from that supports your organization?
From the previous conversation, the licensees.
Okay, I kind of figured that, but I just wanted to make
Sorry.
sure. And also, do you have some sort of idea what the cost would be around creating an auto no fault fee schedule?
So it really depends, and I couldn't answer it because it just depends on how far we go. I mean, is it going to be something that's going to be very specific, very narrow, or is it going to be broad? Are you going to just do medical professional? Or are you going to do facilities? Are you going to do complete basis based on a Medicare plus some commercial analysis? And it really just depends. I can tell you based on our experience, it's not very expensive from the state's perspective, from a funding perspective, from I really have to look at it. I'd have to compare it to some of the other state and some of the other work. I mean, again, it does depend on the how narrow and how large. I can honestly say that I think that we've never had anything over, and I'm guessing at this point, but nothing over 180,000. So that would be all in based on a lot of different work. Thank you. And don't hold me to that because you're going to come back and say, no, I want this plus this and this.
Next, Representative Rogers.
Thank you, Madam Chair. Thank you for your presentation. You mentioned ICD-10 codes and how they inform your decision making when you're looking into the data. But it can be really challenging with this population of auto crash survivors. I just use the example of an ankle sprain. So if I fell down the stairs today here at the Hob and don't have any other comorbidities, the average time it would take to rehab an ankle sprain is about, up to say 6 to 12 weeks. That's kind of a standard kind of thing. And the pricing is pretty standard because I only have one problem wrong with me. When you have an auto crash survivor, it's often multiple comorbidities, multiple ICD-10 codes, potentially a brain injury thrown on top of that with cognitive impairments, so the learning is delayed. How do you account for vastly different when you're comparing to set rates because it's not usually an apples to apples comparison?
So that's a great example where we work with the commission and you put rules in place, and then you can aggregate and you can actually say no less or no more than, and you have a lot of different mechanisms. Different states have different approaches to this, and we bring all of that information in as well to show what has worked and what hasn't. Every year when we go through an update with a fee schedule, we review those rules and we adjust based on what's happened in the state and what hasn't. So the comorbidities, for instance, if there are certain rules, you say if-then, you can put some if-then statements into your rules. So it's not an absolute, it's a maximum allowable with these rules. And that's how you would, and we help define that.
Thank you.
Rep Grant.
Thank you. I know you said that you're unable, of course, to divulge who your clients are or licensees, but do you have a breakdown, and I'm sorry if I missed this, of maybe how many people from each section or segment of the industry? So X amount of home health care providers, X amount of, is there, just so I'm trying to get an idea of the real scope of users. In this conversation, we have different segments of the industry who feel like they were not a part of the initial conversation. And so for me, it's a goal to make sure that we're having everybody at the table looking at your data. I'm just wondering who it's coming from.
Yeah, a great question. So when we're speaking about our licensees, we have different licensees for different products. So we have licensees for our general commercial benchmarks, which a lot of most of the, I'd say, ecosystem would have licenses at this point in time. It's been historically used in the past, and I'm going to put in air quotes, UCR. So a lot of these providers have already been using it. When we look to a fee schedule and a fee schedule benchmark or a fee schedule, then that's going to become a new licensee. So they would have a specific license for this fee schedule, which would be separate from what was a license for our benchmarks. So right now, I think, it's hard for us to say. We can certainly do pie charts, but it's going to be based on different markets. So I'll give you an example. We may have a specialty group, as I know you were looking for home health, but they may be licensing our benchmarks in a general capacity, but not for auto liability. They may be doing it for commercial. So that's where we have a lot of differentiations.
Thank you. And then my second question is, I hear you say a lot about comparisons across the country and who's doing what well. I do know that prior to auto no-fault reform, Michigan was really a leader in a lot of protections for people. Are we able to do comparisons to ourselves, where we were before, where we are now? And I know, and I'm saying this, I know we talk about costs a lot, but when there were some exorbitant costs in the state, it was concentrated in some key areas across the state. There were other people in the state whose fees were reasonable and fine compared to the coverage that they were receiving. So I'm wondering if we're able to compare what we were doing right to expand it versus other states who were looking at us to mirror us.
That is such a great question, and I promise I didn't plant that question. But that is what we do. We will help you do that analysis and look at those that worked well, what didn't, and then try to apply what worked well and even enhance maybe where it worked well and make more clarity. So yes, we do that analysis and help you with that.
I just wanted to also add, actually, if I could, that, sorry to interrupt, when we talk about our benchmarks, we're talking about, when we talk about, not in the context of a fee schedule, but we generally make available, say, like a 50th to the 95th percentile, and it's all by GeoZip, right? So you can say, let's look at, what we would say GeoZip 483 compared to 480, and you can really trend, like, what was the 50th percentile in 2018, and what is it in 2021, what is it in 2023, or the 90th. It's really up to you. We have all that data sort of historically as well, so we can do all those kinds of analyses.
I promise this is my last question. And so how often is your data updated? Is it once or twice a year? Just so we know, because we have a lot of new data in the last few years here.
Right. So we update all of our products twice a year. And again, with respect to fee schedule, that would be up to the stakeholders to determine how, that would be annual or biannual. But all of our products, are sort of commercial products, are refreshed with a new 6 months of data every 6 months, essentially. So it's always a rolling 12-month window of data.
Thank you.
Rep. Harris, Minority Vice Chair Harris.
Thank you, Madam Chair. Thank you guys for being here. So I think there's been a lot of good questions, and so I'm just going to throw out a really simple one for you. It's not even going to get into the weeds. So there's been talk about all the different people that contract with you and licensees and so on and so forth. So as you're here giving testimony today and talking about this very difficult, complex issue, do you think if you came on board and worked on this, do you think you could be fair, impartial, take into account the entire ecosystem, if you will, and help make an equitable type decision on how we proceed?
Yes, 100%, 150% yes. And I would also say you can speak to other states and their agencies, and they will. One of the things that I'm proud of is our team's work has been, again, not marketed, it's more been referrals. And the referrals have actually been our background for that comment. Absolutely. We're fair, we're neutral, and there have been times when some of the chair or some commissions have asked, what do you think? What would you do? And we always say, we're neutral, independent. We cannot make that choice, but let us provide you with more information so that you can make the choice in a sound, supporting manner. So, yeah.
Thank you.
Thank you. Any questions additional? Okay, hearing none. First of all, I really would like to thank you for your presentation. You know, the world of insurance is very complex, and it's not just auto no fault, contrary to popular belief. And I believe this model, I believe this model could be utilized across the board, not only in auto no fault, but as you can see, we just did ACA codification for health insurance. We have life insurance. We have all of these areas where we can bring transparency and accountability as well as specifics. You know what the goal, I believe our goal as a committee is to deliver a product to Michiganders that they can afford, that's quality, without any, the words I use, propaganda. So being that you are, and I want to confirm this, one of the reasons why I asked Fair Health to come here is because they are neutral. Okay, so if they work with our state to develop our fee schedule, help us with our long-term attendant care, these are some of the things that we've heard are the unintended consequences of the reform of 2019. And I thought it would be extremely valuable for this committee to get on the ground level of a non-biased, non-partial, neutral organization that will look at all of our records and help guide us through this process. And I believe this is a start. I believe if none of my colleagues have additional questions on either side, we'd like to thank you, and we look forward to you coming back and giving us more specific data. Thank you so much,
Thank you,
both
Madam
of you.
Chair. Thank you, everyone.
Appreciate it. Thank you so much.
So that ends for today. Some very exciting stuff going forward for the Insurance and Financial Services Committee. So seeing no more business before the committee, I don't think we have anything else, do we?
No absent members either.
No absent members, so I'll entertain a motion to adjourn. And I see Rep. Young is over there. Rep. Young adjourn, and now we are adjourned.